End-of-life counseling, a call to action. I'm Pam Rudisill, a DNP student at Duke University in Durham, North Carolina. Advanced care planning for end-of-life is a crucial conversation for healthcare policymakers, healthcare providers, and all Americans. The goals of this video will be to provide 1, statistics on why this is a national issue, 2, strategies that healthcare providers must implement to assure individual wishes are fulfilled, and 3, the role of healthcare policy in advanced care planning. One provision of the Patient Protection and Affordable Care Act allowed Medicare to reimburse for providing end-of-life counseling. This provision called for educating the public and allowed individuals to customize personal preferences at any time. The provision was eliminated, unfortunately, in Congress. The majority of Americans say that they want to die at home, yet over 75% die in a hospital or nursing home. Lack of education and conversation with patients is documented in the literature as to why the desires are not followed. The Agency for Healthcare Research and Quality Studies has found discussions with physicians about end-of-life counseling led to individual satisfaction. Yet, as many as 3/4 of physicians whose patients with advance directives were unaware that the documents existed. Only 12% of patients with advance directives had received input from their doctor. In addition to the lack of informed education about end-of-life options and adhering to the wishes of patients, the cost of continuous medical interventions has a profound financial burden on the patient as well as the healthcare system. In 2009, Medicare paid out $55 billion for hospital care during the last 2 months of a patient's lives. 5% of Medicare beneficiaries accounted for 30% of all expenditures. 20% of Americans spend their last days in critical care. As we know, many are sedated, and so they won't pull out the many tubes that they have in place. A patient's expense in critical care could cost up to as much as $10,000 per day. A study published in Archives of Internal Medicine in 2009 found patients with advanced cancer who reported having conversations with their physicians had significant lower health care costs in their final week of life. A study published in the October 2011 Journal of the American Medical Association found end-of-life care spending was $5,585 less per person in the dense regions of the Northeast, Texas, and California when someone had an advance directive. So mechanisms for individuals to receive education on end-of-life choices include the media, professional organizations, healthcare provider organizations. Dr. Richard Krumdiek is an expert on the topic on end-of-life counseling. He is a senior partner with Lake Norman Oncology and Hematology and also medical director for oncology at Lake Norman Regional Medical Center in Mooresville, North Carolina. Dr. Krumdiek, thank you for participating in the discussion. Dr. Krumdiek, I would like to get your advice on a couple of topics. The first one, as an oncologist and hematologist, what are your opinions about end-of-life counseling?
Well, Pam, I think it is an essential part of the care that I give cancer patients. In some cases, the goal of cancer treatment is to cure the cancer, for example, in stage 1 lymphoma or a stage 1 breast cancer. In other cases, the goal is to prolong life and maintain a high quality of life. But there are times when I can neither meaningfully prolong life or cure the cancer, and in those situations it is very important for me to provide good end-of-life care.
Well, with that said then, what are some items that are important to cover with end-of-life counseling to your patients?
That's a good question. I do not have a specific list of items. Usually the first thing that I need to get the patient to agree to is to discontinue aggressive life-prolonging care and transition to care whose focus is going to be to improve quality of life for the days that they have remaining. Once I get them to agree to that, then I also discuss advanced directives, specifically whether they want to be resuscitated in the event of a natural death. And you would think that this would naturally follow if they agree to withdraw aggressive care, but many patients don't make that connection. So that is a second important topic. The third thing that I then discuss with them is where they would like to die. In some cases, in most cases, they want to die at home. In other cases, their social situation is such that that is not a reasonable option, and we need to consider other sites of care, such as a hospice home or a nursing home. In some cases, the patient's wishes are not realistic, and I need to counsel them about more realistic options.
Sounds like then it varies then with the course of treatment. When do you discuss the options? Would that be accurate?
Absolutely. I do not discuss end-of-life care with all my patients. In patients, for example, who have an early stage cancer with a very high cure rate, who are young and otherwise healthy, I may not bring up end-of-life care at all with them. In other situations, though, I bring it up early on in the course of their illness. For example, a patient with a newly diagnosed stage 4 pancreatic cancer. There, the treatment, the median survival with treatment may be 6 to 12 months. So in discussing treatment options with that patient, I will discuss standard chemotherapy options, investigational treatments, but I will also discuss with them the option of no treatment at all, and discuss end-of-life care at the outset of their illness. Now, most patients will not accept no treatment as their first option, but I tell them at that initial visit that if ever there comes a time when I believe that the risks of treatment outweigh the benefits, or that additional treatment is not going to meaningfully prolong their life, that I will be forthright with them and tell them so that later in the course of their illness, when that time comes, I can then reference that initial conversation and say, you remember when we discussed that there may come a time that we need to withdraw aggressive care, and they do recall that conversation often, and I use it as a stepping stone for further discussion about end-of-life care.
Finally then, what are your thoughts on whether or not healthcare providers should be reimbursed for end-of-life counseling?
Well, that is a huge topic, and it's certainly not an area of expertise of mine. In general, I think that reimbursement in healthcare is skewed toward reimbursing for procedures and not reimbursing adequately for cognitive input. So that we are actually more incentivized to promote the next treatment than we are to counsel a patient to withdraw aggressive care. I think that the way medicine is reimbursed certainly needs to be revised, and in doing so, I would certainly hope that we are reimbursed for our cognitive input, for counseling, for coordination of care in a more fair manner.
Thank you so much for your expertise on this subject.
Well, thank you for inviting me to speak with you.
Thank you. From a personal perspective, Dr. Krumdiek cared for both my parents when they were diagnosed with terminal cancer. Fortunately, both parents were informed and had advanced directives. With the beginning diagnosis, perhaps it was my critical care background and the fact that I wanted my parents to live as long as possible, it was very difficult for me not to want all the aggressive care for both of them. It was Dr. Krumdiek, through his counseling and talking with me, my sister, and both my parents, that I came to realize they needed to die with dignity, they needed to be pain-free, and they needed to be in a comfortable, loving environment that hospice and palliative care provided. In summary, action items that are imperative for all Americans include: 1. National healthcare agencies must continue to address this issue. To that end, the Institute for Healthcare Improvement has published the 6 leadership actions for end of life, which are listed on this slide. 2, hospitals and healthcare providers are obligated to collaborate and coordinate care of patients with hospice and palliative care. They must also have systems and structures in place to monitor outcomes with advanced directive education initiatives. 3, the Centers for Medicare and Medicaid must establish standards for assuring that end-of-life education is provided to all Americans. 4, it is essential that healthcare policymakers address the issue of more fairly reimbursing for end-of-life counseling. And I encourage everyone to contact your local legislators to address this issue. Each American must be provided with end-of-life education and discuss decisions with family members and healthcare providers. It is morally and ethically the right thing for us and the healthcare system in our country. Thank you.